Well, thank you. You've obviously seen me most of yesterday, and you're seeing me again today, I'm afraid. So this talk is hopefully will expand your horizons, inspire you to perhaps consider doing research in your own countries, and improve your management of this patient group, and looking how we should assess and treat them. And we'll obviously link in with some of the talks from yesterday in terms of the neurological aspects of pain. So yes, I'm currently working at Forth Valley, which is in Scotland. Scotland is still part of the UK, despite a close vote recently, and may it remain so because it's in the economic benefits of the region to actually stay together rather than start talking about separatist action. Anyway, moving on. So I have some disclosures to make. So I have received educational grants and done some speaker meetings for those various companies. So let's talk about orthopedics and rheumatology, and I'm just going to take my jacket off so we can have a more relaxed atmosphere. So it's been around for a long time, the problems related to orthopedics and rheumatology in different guises and different forms. And various parts of the world have developed ways of treating orthopedic problems and rheumatological problems. From a fracture management aspect, we know that from the 6th century, the famous Ayurvedic physician Susruta had developed methods of managing fractures and broken bones, and that link can be found on Wikipedia. We also have evidence from the ancient Egyptians, time during Hippocrates, also from China, and the fact that actually plaster of Paris is actually plaster of West Asia, because that's where the procedure was actually discovered. So that should be reclassified at some stage in the future. So the actual name of orthopedics was actually developed by a guy called Professor Nicholas Andre, who did the ingenious orthopedic procedure of fusing two words together, orthos meaning straight and padios meaning free from deformity, and that was his desire to try and improve children who had deformities in his practice in France. He was professor of medicine in Paris. It wasn't until 1887 that we had the first formal orthopedics association in the world that was formed in the US. And this is by, at the time, as we have a lot of these specialities, it was by general surgeons who had an interest in the musculoskeletal system. And so, as you know, from a historical perspective, it was generalists who sort of treated a lot of the diseases. From a rheumatological perspective, Church, founder of BC, the famous Ayurvedic physician, who was around a similar sort of time as Hippocrates, described many treatments for the treatment of arthritis, including oxidized gold salts. And Hippocrates gave the name rheuma, which obviously went into rheumatology, meaning flowing. And obviously the idea is we've got to keep ourselves flowing. In terms of the history of pain, I'm giving you sort of two angles to the history here. And we have Descartes, who was in Europe and felt that pain was at the time had theorized that pain was actually disturbance on the nerve fibers that caused disturbance reaching the mind. And that really transformed some of the thinking then, that felt that it was actually some kind of spiritual mystical experience and should be treated by seeking God. Obviously, prior to that in Asia, 6,000 as far back as 6,000 BC, there's evidence that actually acupuncture and actually was around and actually recognized that pain was actually an entity that could be treated, and not just by seeking God, with actual physical management. So that really tells you actually, you know, that pain has been recognized as a problem for a long time, and it continues to be treated, even though the studies may suggest that perhaps acupuncture has variable results. In terms of chronic pain prevalence, we have various studies from various parts of the world, and obviously it's about 19% in European countries, and those countries with European origin populations, such as Canada, and also Australia to a degree. In the Indian population, there's a point prevalence study done by Deraja et al. Recently, shows it to be 13%, but then there's a study done by some chaps in rural Tamil Nadu in their medical clinics who found it to be 51%. But there's obviously maybe a case bias there, because obviously people attend the medical camps will have medical problems, so there's a bias in that study. And interestingly, the Swedish population seem to have a high prevalence of chronic pain. Maybe it's really bad living up north. Anyway, in terms from other perspectives, in terms of consultations, 22.5% of primary care consultations form some form of chronic pain. It's also worth noting that musculoskeletal problems account for 25 to 30% of primary care consultations, yet only a fraction of those practitioners have had any formal training in rheumatology or orthopedics. A German study showed that chronic pain was formed 42.4% of the consultations there, or it actually involved some form of pain, I should say. I apologise for that. So that included chronic and acute pain. And it's worth noticing again, only a fraction have had, if any, training or in pain management. Now, I apologise for not putting the reference there. I did have it, but it's just couldn't find it when I wanted to find it, when I needed it. But actually, this is some factual data that 57% of consultations in pain clinics involve patients with some form of musculoskeletal problem. Yet only a fraction of pain physicians have had any formal training in orthopedics or rheumatology. Make your own sort of decisions on that data and that fact, but that is actually factual data. So, is pain actually crowding the company of orthopedics and rheumatology? You know, orthopedics and rheumatology together, biomedical approach. You know, we're all, thinking it's two's company, that's it, three's a crowd. So, let's look first at the ISP definition, which is the International Association for the Study of Pain. And essentially what it says is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So if you think of it about that, that refers to all of our patients. All of our patients who come and see us on a regular basis, on a daily basis, have something going on with them that accounts for this. They may be emotionally upset because something's not quite right, but there's something going on that accounts for that whole distress process and obviously association with chronic disease. So, has this relationship only a recent thing? Because obviously pain is becoming more and more apparent now. They're saying it's the fifth vital sign and we should be taking it seriously. It's a hidden epidemic, even though it's been around for a long time. Hidden, perhaps more ignored epidemic probably, because it's always been shifted to the pain physicians who've had no training in the musculoskeletal problems that cover most of the problems. So I did a sort of quick search in orthopedics and pain and found that orthopedics were in there back from 1933, and I was quite impressed. You guys care. You do care about the pain your patients have. It's the banter. Anyway, and you do have feelings, which is good. And you do recognise pain is an important part of clinical practice. So, I was quite impressed by that. But I was shocked by this. And I thought, my God, pain's been having it off with orthopedics since 1933, certainly according to official literature. Our guys in rheumatology have taken 15 years to catch up. Clearly, orthopedics getting straight in there, and rheumatology taking their time to ruminate and think, do we really want to have this? Anyway, so hats off to orthopedics, well done. So most of us have a patient who will have some form of chronic pain. We have the orthopedic patient who's had knee replacement or a hip replacement that hasn't worked and hasn't taken away the patient's pain. And I know a rheumatology patient with the chronic disease who've been treated effectively for their inflammatory arthritis, but have ongoing pain features despite the treatment and have to be treated with, we keep rolling around with the various drugs that we have to try and work out, is it inflammatory or is it degenerative or is it just a chronic pain aspect, which is often labelled as. And often these patients get labelled as mad, sad or bad, or occasionally bad in terms of how they are, because obviously the pain can affect their psychological health and drive them mad because it affects their ability to function and do things and to be normal and have a lower level of, have a good reserve in terms of dealing with everyday life. So, pain, the companion to both orthopedics and rheumatology. So let's go to a traditional pain theory, which I think has probably been around, for a long time, but it's been crystallized in the 1965 paper by Melzack and Wall. And if you look here, I'll come away from the microphone and explain, because you can hear my voice at the back, can't you, quite easily. So I'm loud enough as I am. Do I have to get the microphone on, do I? Oh, God, right, okay. That'd be easier. But I won't. Okay. So, so if you look here at this, is there a laser on this? Yes, a laser on the middle. Right, fine. Okay, so essentially, pain. So somebody hits you. That hurts. Pain goes to the gate, gets transmitted by the transmission nerve cells according to the gate control theory to the brain. The brain goes, okay, you've just hit me. And then the brain sends messages down saying, why have you hit me? and trying to deal with that, and am I going to hit the person back? But then you think, you start rubbing the affected area, for example, and that causes an element of distraction from that and reduces the pain and re-educates the whole thing. So you've got pain signals going in, and you've got this area where you're rubbing that area to try and reduce the pain through a different set of signals, and that will, in this whole cycle, lead to some reduction in the pain. And maybe the person's hit has run away. But anyway, but that should hopefully explain to you, or give you an idea of what happens in that sort of gate control theory. You get hurt, you rub it, that's why the pain reduces. That gives you a general, crude way of understanding this whole process. But now, everything's plastic. You know, that's gone now. Just like the WHO pain ladder, that's gone. You know, that's in the past. And, you know, we're into this new age of plasticity. Everything is plastic. You know, we have myoplasticity. You know, there's a recent geriatric medicine conference in Oslo. And it's interesting, they're saying, actually, no, old people, you're not old. You've got muscle, you can function. You know, you have still some muscle function left. You can still build it up. Take these supplements, GHB, and it will enhance your ability to build up your protein, your muscle mass, and get you back on form with appropriate physiotherapy. So we have myoplasticity now. We have osteoplasticity. We've had it for a long time. You know, if you think about it, we treat our patients for osteoporosis and fractures. So with various drugs that modulate the whole bone turnover process, and that is in some form of plasticity. We're playing with bone. And a recent talk, it was yesterday, was saying about using parathyroid hormone to treat fractures as well. And we have neuroplasticity. So what is neuroplasticity? Well, it's not Melzack and Wall, which was the gate control theory, which gave us a base for understanding pain, and regard the whole nervous system as a static organ which does not change after adulthood. But it's actually an umbrella term which includes synaptic and non-synaptic plasticity and their relation to changes in behavior, environment, neural processes, thinking and emotion. So you'll understand basically if you're feeling very anxious and stressed and you get pain, your pain levels your pain's going to be much higher. Your reserve is going to be lower. Your actual reserve for triggering the pain is going to be much lower as well. So even the slightest touch can wind you up. So whereas if you have a good reserve, obviously that's a different thing. So you'll notice in your patients how different patients with different psychological makeups will have different responses to pain. So these are changes that occur at various levels, at cellular levels and large-scale levels as well. Now I'm going to play this YouTube video, so if you just bear with me. It's connected to the internet, is it? So I'm just going to just copy and paste this. So if you just bear with me, I'm just going to end the show. And then... Right, okay, well, sorry about that. Technical issue. So an example of neuroplasticity is something which Ramachandran and Blakesley noticed in 1998 in their paper on treating phantom limb pain. And it's a process that's used also in treating people for stroke rehabilitation with the problems that they have with pain as well. And it's a way of feeding back and re-educating the brain. So people who've had amputation still have ongoing pain issues related to that amputation. And it's a way of also getting the brain to look at the mirrors and just looking at it and re-educating themselves, saying, actually, I've got a normal hand. And that is a way of treating pain. And that's almost like, if you think about it, it's going through that. You can use that neuroplasticity model on the Melzack and Wall model, mix that in and understand how that whole feedback process takes place in re-educating what's really going on. So really the mirrors are kind of like a rubbing mechanism to say things are okay and getting better. So think of it that way. Does that help you understand that process and that whole idea? Okay. So the implications are potentially in the way we treat these patient groups. There's huge potential. We may reduce the need for pain medications, disease-modifying agents, and also may reduce the need for operations. But I'm sure you'll still be doing total knees and total hips for a long time to come, especially with the increasing aging population. So what links all three specialities? We know it's obviously arthritis, which is why we're here at this meeting today. So let's look at osteoarthritis in terms of pain. We have an increasing aging population. This is an increasing case of osteoarthritis as a result of that across European, North American and Asian populations, something where there is sort of less conflict and more an increasing aging populations as such. From a NICE guidance recently, we know that greater than the age of 45 increases the risk of, you've got a higher risk of getting osteoarthritis. As a greater female to male risk factors. So linking in with Garima Gupta's talk yesterday, in terms of muscle and proprioceptive factors, it gives you a neurological aspect to the pain itself. So we know that muscle weakness there's reduced, as soon as we get pain in our knees, the first muscles that go are the quadriceps, especially because we sit down when you're not ill, when you're not well, when you sit down, you lie down, your quad muscles are the first ones to go. And that leads to further problems into almost a vicious cycle of problems that can occur. We know, and some of these are from up to date, so in terms of muscle strength, with the grip strength, this is an interesting fact that there's a threefold increase of OA of the PIP, MCP, and first MCMC joints in terms of if you have a strong grip when you shake someone's hand. And in terms of, for females, increasing now in the MCP joints. Now, coming to proprioception, we know that this is abnormal bilaterally, even if you've got unilateral OA of the knee. And that's obviously because of the signal that gets sent up. You've got pain in your knee. You think, right, okay, I've got pain. If I walk less, I have less problems. That has an effect on the contralateral knee. As a consequence of that is a further vicious cycle, and you get further problems then in that knee afterwards. And there's a common thing where patients say to you, I think I'm putting more pressure on the other knee, and that's causing further problems as well. We also know that there's a slowing of periarticular muscle reflexes that potentially can occur because of this neurological change. And this is an example of neuroplasticity that occurs, is that the changes that occur between the cells, up and down, that cause these changes to occur between the afferent and efferent connections of the nervous system. And there's evidence that the afferent input from OA knees is abnormal, leading to abnormal efferent signal in the quadriceps muscle, which again leads into the first point of proprioception. So that really tells you the neurological elements of what's going on with this patient group in the nerve system, because of pain, and pain is part of that. So in terms of non-pharmacological therapy, these are well documented. So we know we have a number of self-management education programs with good support, which is needed. Weight loss, as we know, has been proven to actually improve symptoms and signs of OA with increased joint space and reduced pain. Physiotherapy has its place, range of movement and exercise, flexibility exercises, etc. So there's a whole series of things of non-pharmacological therapeutic techniques that we can use that's in the armamentarium to actually treat this patient group prior to any surgical therapy. And for the purpose of the talk, I'm going to focus on the knee brace, which, you know, depending on which guidelines you follow, has had variable viewpoints on that. And, you know, thermal therapy or water therapy obviously there in terms of giving distraction from the actual initial pain process, and again past that almost that rubbing aspect to the pain that re-educates things aren't as bad as they seem, and distracting the pain from the original cause of the pain. So in terms of, I'm going to concentrate on the knee brace studies, OA studies. The knee braces have been around for a long time, and the problem we have with these braces is actually compliance. You know, we know at 2.5 years that compliance is much less, and patients seem to think, as I was discussing with Graham Gupta yesterday, that patients have this idea that they just want a tablet to fix the problem or an operation, and not actually realise that they've actually got to do something about it themselves, which will involve physiotherapy and exercises and weight loss. And as a consequence of that, giving them a knee brace, while you think on the face of it is actually very good, again, there's a problem of compliance, and the older the patient, the less compliant they are. The younger the patient, the more compliant they are and more motivated they are. So studies have shown there's actually a lot of positive benefit. Now, the studies are mixed, because the problem we've had with the studies is that I've only included those studies that have had 25 patients or more, because obviously 25 patients is a reasonable number to have a pilot study in this area. And despite the fact that OA is actually quite common, there are very few very big studies looking at the use of the knee brace in this area, which is actually quite a cost-effective, cheap way of getting somebody better and avoiding an expensive operation, especially in the developing world. So, you know, I just want to sort of encourage those of you in the audience who are from, you know, various health economies to actually look at this as a cost-effective way of, you know, reducing health costs and getting the patient to stand on their own 2 feet and get things done themselves. So we know that from 1999 that Kasturagawa showed that there was an improvement in bone density, interestingly. And why does that happen? We know why. Because obviously you sit down, you lie down, you don't do very much, your bone density goes down, because obviously bone densities depend on weight-bearing exercise, especially in our lower limbs. So a knee brace goes on, right, great, walking around, the bone starts thinking, oh, right, okay, we're doing some weight bearing here. And not surprisingly, bone density will improve and reduce risk of osteoporosis and fractures if the patient does fall. There's also improved function, we know, with the actual knee brace, and there's improved proprioception as well. So leading back in with the proprioception aspects of knee OA and the problems we have with actual perception of what's going on, the brain thinks, oh, right, I've got some support now, I can walk and feel more confident in that. And leads to a positive impact on the efferent side to actually encourage further function and reduce pain. There's increased walking distance and reduced pain and disability, and reduction in pain and improved mobility when combined with transelectrical joint stimulation as well, obviously avoiding patients with pacemakers. But the problem with most of the studies is that they're all a lot more small studies, and they still get published, which I wonder why, because really, we're looking at quality of studies, especially now. We should be looking at a minimum of 25 patients, really, for a good pilot study to actually give us good results. And the very fact we've got studies already here showing what's going on, but these are some of the small, some of the large. We need a good, 200, 300, 500 patient study that shows actually this is the thing to use. There's huge evidence supporting this, a good multi-center study to actually do that. So, you're all here today. It's something to think about as a piece of research that can be done and coordinated very easily with the right clinical guidelines and the right ethical input as well. So I'm encouraging you guys to think about doing that, because this is what we need. This is what the health economies need, is good evidence of supporting, no disrespect to the orthopedic surgeons, but, we need good evidence for this, so that then when patients do finally end up at the end of the line, they'd get the orthopedic surgery they need, and it reduces costs. So I've already talked about the whole thing pretty much there in terms of how the whole thing, knee brace, re-educates your brain and helps function. So that kind of covers what I've discussed in that previous slide. So moving on to rheumatoid arthritis, and you're thinking, rheumatoid arthritis and neurology, where's this guy going? So we know it's an autoimmune disease. It's an autoimmune disease to the synovium in our body, and that affects various parts of the body. It generally affects the small joints. Dr. Waslauskas talked about the diagnostic criteria, which it's actually a classification criteria, but there's obviously a difference of opinion. We had a discussion yesterday whereby there is a school of thought that says use classification criteria for diagnosis, and only use classification criteria, those are purists, for research. But then obviously if the patient classifies for research, they've obviously got the disease. So anyway, I think we need an article on that saying when can classification criteria be used for diagnosis safely. So we know it causes pain and stiffness, unlike OA, which causes pain and mobility. Causes joint swelling. Presentations can be variable. And as we know, we've had those patients, those of us who are rheumatologists, or we've seen patients with rheumatological problems or complications of rheumatoid arthritis. You can have a huge spectrum. Those who have mild disease or responded very well to disease-modifying drugs, and those who haven't responded have had to cycle through the various drugs because either they've got very active disease or there is some kind of psychosocial aspect to their disease process that's enhancing their progress towards stronger therapy. So, and we know there's an increase in white cell migration. The drugs that we use in inflammatory arthritis are used to modify white cell migration. Anti-inflammatories reduce inflammation, reduce cytokine production, and reduce migration of white cells. Same thing with methotrexate, leflunomide, and other drugs as well. They have their effect on that migration of the white cell to the synovium to cause the inflammation. And obviously everywhere else as well, which is why the increased risk of infections. So we move to the vagus nerve. Now, some of you may have seen the program, I don't know, but you're probably thinking, why the vagus nerve? So obviously notice cranial nerve 10, it's the parasympathetic backbone for the body. It counteracts obviously the sympathetic system. We know all from biology, and there's the various organs it has an effect on from a parasympathetic point of view, and including, interestingly, the spleen, which I thought was quite interesting, because obviously I missed that during my revision in undergraduate school. So the vagus nerve and the immune system. Now, this is the article I recommend you look at if you're interested. It's free, it's online. It gives you a good view of what's going on. Now, interesting, the guy who actually looked at this area initially was a guy called Tracy, who's a neurosurgeon based here in the US, who, interesting for a neurosurgeon, was also interested in integrating things and looking at what's really going on with this patient group, and looked at this disease area. So he's the one who did a lot of work in this disease area. So if you go on Wikipedia, you'll find on Wikipedia about the vagus nerve and immune system, vagus nerve stimulation, and you'll notice all the people have done their role in this. So basically TAC is a Dutch group. All they've done basically is take that work forward even further. So that's the article to look at. It's free, it's online, and it's worthwhile looking at if you get a chance. And there's a huge wealth of information there. So basically, as what this vagus nerve has taught us is that the afferent aspect of the vagus nerve detects inflammation in the body. So the nerves are all over. Yes, it supplies all those various organs, but it detects inflammation that's going on. And the information is signaled to the brain. That's obviously by the increased number of white cells and cytokines that are going around and stimulating it. And as a consequence, what we've noticed in animal studies is that the sensing inflammation of the vagus nerve can also influence this by reducing inflammation as well. And so there's a cholinergic inflammatory pathway. So the receptor involved is the acetylcholine effect on the nicotinic acetylcholine receptor type 7. Now, I was hoping Dr. Shankar would be here today because I did a bit more reading on this area. But essentially, it's interesting that it's a nicotinic receptor. And you think, well, hold on. Guys who smoke, they take nicotine. Yet smoking is associated with rheumatoid arthritis. So why are they not getting reduced inflammation if they're stimulating that receptor, which is leading to the whole reduction in the inflammatory process? And the answer is quite simple, obviously, is because they're inflaming their lungs, and maybe there's something going on where there's some common tissue there in the lungs with the synovium that's triggering things. It's the smoke that causes problems, because people who have snuff have less issues. That's tobacco, but it's just inhale through your nose, straight in, no problems with your lungs. They have less problems with rheumatoid arthritis. So it's interesting, not the paradox, but the actual difference is that it's what you take. So maybe I should be encouraging my patients to take snuff rather than the electric cigarette to reduce their smoking. But anyway, as I said, this receptors are found on a variety of cells and has been shown to actually lead to reduction in inflammation. So apologies for the coming through the picture, but you'll find on the paper the actual picture on the paper itself. But the vagus nerve stimulator goes in, and I'll just point to it here. That's where it sits there next to the vagus nerve. Signals are sent down to the spleen. This reduces production of systemic inflammation and reduces the migration of immune cells to the area causing the disease process. So there's actually a benefit with that. The study's been quite small, but they're saying there's potential benefit with that. We're waiting for bigger studies to come out. The study, and that will hopefully give us some idea of how the vagus nerve stimulation can be used to help treat a certain group of patients. And it's interesting, actually, it's been around for a long time. It's approved for use in epilepsy and depression. And 100,000 have been fitted so far, so it's quite safe. There's good safety data for this, and it's worth considering. But obviously, we need a good multi-center study to actually show that this works very well as an alternative to patients who can't, maybe are intolerant of disease-modifying drugs, or are not suitable for having biologic drugs, such as anti-TNF or the IL-6 blockers or rituximab. So this is a very good alternative and a very fantastic development in the neuro aspects of treating pain and inflammation. Now, can you stop recording now, please, John? John? Just stop recording now, because this is actually this is not published work just yet. That's an important question. So sorry, Carrie, just ask the question again in an abridged version. Sorry.
Okay. Chronic pain has often been associated with anxiety and depression. I have found in my personal experience that in a number of cases, these patients have difficulty eating, sleeping, loss of appetite, have a significant stressor in their life, for example, marital issues, job-related issues, etc. It is something that I initially found anecdotally, and then at a pain conference, numerous psychiatrists had presented on chronic pain and had even admitted that initially this was a conference last year, so fairly recent. And numerous psychiatrists had found that this was even outside of their comfort zone, and this was now something that they're now becoming appreciative of, because initially they were just treating with the standard antipsychotic agents, etc. So it is now evolving more and more that this is a large component of chronic pain. So I wanted to find out what's your experience and how does it affect your treatment management, in particular these cases. And then what I didn't ask previously was, I also have a problem with workers' compensation patients, people that have whiplash injuries, chronic back issues, and they are doctor shopping. How do you treat those patients if they actually come to you? Because I know orthopedists would see that more commonly.
Okay, right. I'll answer those. Obviously, it's two parts of the question there. So coming to the first question, essentially all a lot of patients I see with chronic pain invariably will have some form of anxiety or depression. Those patients invariably be on some form of therapy prior to being referred to me as a general physician and rheumatologist. And so we'll be treated by the GP for some kind of anxiety or depression. So I think it's important to recognise that is a vital component of that. I do, as a standard practice, assess these patients if I suspect that these patients, as you've quite clearly listed, that they do have other factors going on. And often when they come and see you, they have a huge barrage of things to tell you, and you're sitting there going like, well, it ain't a knee problem, isn't it? It's a whole body problem. And you realise actually where they've got a whole load to offload on you because nobody else is listening to their problem. So you're telling them basically, look, they're telling you everything, and you're sitting there listening patiently and trying to decipher between what they're saying, actually what the salient points are. And at some stage of the consultation, you have to take control, obviously, and ask them very specific questions. So what I do generally is do an anxiety and depression questionnaire. There are enough anxiety and depression questionnaires online that have been validated, that for free, that you can do. Historically, I used a hospital anxiety and depression questionnaire, but that's been hijacked by a private company, even though it's produced in the NHS. So I've not been able to use that properly, whereas the Zung anxiety and depression questionnaires are actually on the are quite readily available online, as well as many others. And you can have loads on your iPhone as well that you can use. I'm sure, Lloyd, in your practice in dermatology, you have problems with psoriasis and the psychological aspects of that, as well as any chronic disease as well. So yes, in answer to that question is, assess them, number one, if you suspect it. Number two, if you feel you're allowed to, start treatment, because I want to make sure that you're not practicing outside your own practice as an orthopedic surgeon. You are a doctor, you've got an MBBS or MBCHB, you have been trained in some psychiatry, you've probably had as much psychiatry training as most doctors have had in the health service, unless you've actually gone through psychiatry itself. So I don't know how the regulatory processes are in Jamaica or in other parts of the world, but certainly I think treating them is nothing wrong with that if you suspect it, or recommend to the primary care physician to consider treatment for them, because this is what you found, and that way then it protects you legally, and then you can say to them, right, I've referred it to that person. And also I recommend to patients CBT, which is cognitive behavioural therapy. So that helps with anxiety and depression and has an MBT effect, or a PBT effect, the pain behavioural therapy re-education program. So obviously it's how they perceive things, the world around them, because they do catastrophize a lot. So obviously, there's a book called CBT for Dummies, which is they can use themselves and teach themselves. There's a lot of stuff online. A lot of primary care physicians are recommending their patients to online things like Mind Gym and other things to help patients look at life and think things aren't as bad as they seem, and put things in context and rationalize things as well. So I recommend that as well to my patients as well, and that's very, very helpful. And so you have to get them to do some of the work themselves, and saying a drug's not going to fix it because that only fix 30%. It's the other stuff that you do around that that's going to help you. And obviously, if they've got weight issues, because some of these patients will be comfort eating, so losing their weight and reducing their appetite, that helps as well. Now, in relation to your second, does that answer your question? Yes. Good, right. Now, in relation to your second part of the question, in relation to these patients who are shopping, it's quite straightforward. With whiplash, if it lasts more than 2 years, and they have clinical features suggestive of pain, which looks to you, because you're an experienced doctor, you'll know what's pain and what isn't, then, chances are something else is going on, because whiplash normally lasts for no more than 2 years. And the same goes for low back pain, post-trauma. Probably road traffic accident or some kind of trauma. If it's going for more than 2 years, something else is going on. And what you can do is get an MRI scan of the neck or the lower back, or get appropriate ultrasound of various joints that are causing problems by an experienced, board-certified musculoskeletal radiologist who's actually up to date with the actual guidelines that are there internationally. Okay? And I'm sure you know what I mean, Lloyd. Carrie. In terms of that respect. So it's important you have a proper board-certified person who's been trained to the international level, who knows what's going on internationally, who goes to these conferences and practices that kind of radiology, because a lot of stuff has come in the last 10 years. I'll give you an example. A study was done in the UK looking at radiologists, and they found that 75% of those radiologists who reported on musculoskeletal MRI scans did not know what they were looking at, in terms of they weren't up to date with what was going on. Yet they labelled themselves as musculoskeletal radiologists, but only 25% knew what they were looking at. So that just gives an example. That's a factual study that's been done. It's been published in the British Society of Rheumatology abstract. The guy who's done the research is hoping to publish it soon. So that is fact. So if anyone wants to criticise me and tell me off, they can say, well, you can speak to this guy. Okay. Any other questions does anybody have? Yes.
Okay, just the last question because we're running on lack on time.
Right, okay.
I'm free at the break, by the way, if you want to speak to me.
Yes, Michael Yelland, I do musculoskeletal medicine in Australia, which is a special interest area where we tend to focus quite a lot on pain, perhaps not enough on disability. When you see patients coming from pain management programs, the focus seems to be too much on disability, and they say give up hope of recovering from the pain. It takes me a long time to give up hope on helping patients with pain, and you find that as people's pain improves, often it returns back to almost where it was because they increase their activity. They sort of push the limits of their activity. Would you like to comment on that?
So hold on. So
well, you talked mainly about pain, but you didn't talk much about disability today. That's another dimension of this whole.
Right. So what you're saying essentially is that when you encourage patients,
I suppose I'm calling for a broader sort of assessment of outcomes. I suppose that includes pain and disability and balances those up to see how you're going, because the pain may just continue roughly at the same level or improve just a little bit, but their disability may be the thing that improves most of all.
Well, that comes down to, again, the psychological perception of what's going on and how they've been treated before, or whether they've been treated effectively or not. And I do question sometimes whether my colleagues actually know what they're treating in terms of, have they analysed the pain correctly? So, as we all know, we should know, there's three kinds of pain: nociceptive, neuropathic, and central. And for each of those aspects, there's different drugs to treat all those three aspects of the patient. So it's important that we treat the appropriate aspects of the pain first. So if they have got generalized osteoarthritis, for example, they're treated with appropriate painkillers, not just paracetamol, but consider anti-inflammatories. And if they're older, low-dose non-steroidals with PPI cover. So that's with the appropriate acid cover. That's the national and international guidelines that we're using in the US and the UK. So those are things. I think it's integrating everything together to improve their pain management, which has a knock-on effect of reducing their disability, and has a knock-on effect then of improving their overall ability to get around, and obviously a knock-on effect of actually reducing their pain. And obviously the psychological aspect of that is bringing in the actual treating their anxiety and depression or any other factors that they have, and CBT and other things will help with managing that pain and thinking, well, actually things aren't that bad. Also activity management. So, for a long time I used to advise my patients, say, well, look, what do you have to do in the day? So what you do is you take your painkillers in the morning. You do your 2 to 3 hours you need to do in the morning, take a rest for about 2 hours at lunchtime, take some more painkillers in the afternoon, get through your afternoon, and then you're in the evening, you can wind down. So plan your day that way. Don't think you can do everything. Stop being an everything person. It's an everything lifestyle, and everything can do everything. No. Do what you can, what is realistically achievable, and then set your goals realistically.
Can I get on with the next speaker, please? Thank you. Sorry.
Okay. Sorry,
yeah, we have to keep a tight time schedule today.
Okay,
Thank you.
Okay, so I'll give you... leave that. Okay, do that quickly. Okay.